So one is for the urine to come out, right? One's for the balloon, and then the third is for the irrigant, right? So if a patient is on an irrigation, right, and you have 2 liters over your shift, which is equal to 8 hours, and at the end of your shift, your output was 3,102 mLs. What is the patient's urine output? Your total output was 3,102, but you can't put that on your INO, right? I'm sorry. You can't put that on your INO because that's not correct. So what's the total output that this patient had?
1,102.
How much did the patient have?
How did you do that?
How did you get that?
Just take the 3,000. Subtract
Don't
2,000.
rote knowledge. How did you get it? So you have to put total of what the patient had out, right? The patient had what, 3,002 out ml. That's the total. However, how much was put in? 2 liters. 0, 0, 0. So you minus that. That will be your output. So 2, 0, 1, 1. Patient had 1,102 mLs output. Everybody understand that?
Wait, what is that? The first sentence?
Sorry, that's my writing. 2 liters over your shift. If you put the 31 in there, right, that doctor is going to be extremely confused and wonder why is this patient having so much output. Any questions on that? So remember your anatomy here. We've got 2 kidneys. We've got 2 ureters. They drain into the bladder. Do anybody remember the muscle that supports that bladder? Give a pass to you. I'll give you a point without looking up. Go from your anatomy and physiology. No.
Your pelvic floor muscles?
Nobody knows it. The detrusor muscles, right? The detrusor muscles. I don't have it on there.
What is it? The truther
The
muscle?
detrusor muscles.
It's right there.
Pardon me?
It's right there.
It's, oh, there it is, the detrusor muscles. I thought I had it on there. The detrusor muscles. Thank you, it's right there. She showed it right here. The detrusor muscles. Right, those are the muscles in your bladder. Okay, so the kidney are on either side, right? Where urine is produced, urine travels down that urethra. It's stored in the bladder. When needed, the bladder will contract and release urine, which travels down the urethra and then outside the body. The bladder is made up of a muscle called the detrusor muscle, therefore can contract and relax. There are 2 sphincters, the internal and the external. Between the 2 sphincters are the prostate gland, which is only found in male, and the role is to activate sperm. So that's why they have that. Prostate hyperplasia can cause an obstruction. So if the prostate gets too large, it will cause an obstruction in the urinary flow. So as men get older, right, that's why you'll hear them say, you know, the flow is not as strong. Or that's why they can't impregnate the womb. The tract is different in female. Female do not have an internal sphincter, but they do have an external sphincter. The urethra is a lot shorter than that of a man. Because female urethra is shorter, there is a greater risk of UTI. Okay. Urine is produced in the kidneys, right? It travels down the urethra into the urinary bladder. The bladder expands like an elastic sac to hold more urine. As it reaches capacity, the process of micturition or urination begins. Involuntary muscle movement sends signals to the nervous system, putting the decision to urinate under conscious control. So all of a sudden, you know you need to urinate. But because it's now under voluntary control, you can hold it. You can say, okay, I'll wait until the break before I go, or I'll do it right here in my pants, whichever you want. The initial urethral sphincter and external urethral sphincter both provide muscle control to the flow of urine. The internal sphincter is involuntary. It surrounds the opening of the bladder to the urethra and relaxes when urine is passed. The external sphincter, again, is voluntary. It surrounds the urethra opening of the bladder and must be relaxed for urination. The bladder, what is the bladder shaped like? Yeah, it is shaped like a pyramid when empty. So when it's empty, it becomes more oval or like a ball when it's filled with urine and expand. The smooth muscle, again, what's that smooth muscle called? The detrusor muscles surround the body and flow and folds, and they fold into like what we call rugae, right? Micturition or urination is an act of emptying that bladder. When the bladder is full of urine, stretch receptors in the bladder wall trigger micturition reflexes. The detrusor muscle then surrounds the bladder and it contracts. The internal sphincter relaxes, allowing urine to pass into the bladder, into the urethra. The bladder expands as urine flow from the urethra, but it is limited in volume. It's about 200 mLs of urine. Depends. At about 200 mLs of urine, the detrusor muscles begin to contract. So when you get about 200 mLs in there, the muscle says, hey, I need to release this. And the internal urethral sphincter muscles begin to relax. This sends signals through the nervous system that creates the urge to urinate. If this urge is ignored, continence may be threatened. At about 500 mLs, the detrusor muscle contraction begins to force opening, or the opening of that bladder. So between 200 to 500 is how much a bladder can hold then, right? Unless the external sphincter is powerful enough to prevent it, micturition will occur involuntary. So if you have too much pee in there, it's going to force against that sphincter and somebody will become incontinent. Smooth muscle stretches initiate micturition reflex by activating the stretch receptors in the bladder wall. The autonomic reflex causes the detrusor muscle to contract and the internal urethral sphincter muscle is relaxed, allowing urine to flow out. The stretch receptors also send message to the thalamus and to the cerebral cortex, giving voluntary control over the external urethral sphincter. We usually gain control of the sphincter somewhere between 2 years and 3 years. Some kids, 18 months, if they're pretty bright kids, right? Urine storage and emptying are highly dependent on these pathways that we see. For these reasons, neurological function and autonomic abnormalities can involve many disease states such as incontinence, obstruction, or infection. Due to intrinsic and extrinsic nature of the urinary tract system, pathologies can range from neurological, obstructional, or infection. So we need to rule out what is going on. Because of the physiological function, the urinary tract is prone to UTI. However, women are more prone to UTIs, right? Men very seldom will get a UTI. When a young man gets a UTI, right, we're gonna check them for STDs. Urethriasis is more common in female because of the short urethral length and the proximation to the anus. Cystitis and inflammation of the bladder can present with suprapubic pain. Where's your suprapubic area? So it's right above the where's my umbilicus? I don't even know. Right below the umbilicus, right, is that suprapubic area. So find your belly button, and right below it will be that suprapubic area. Call it, yeah.
You said women don't have an internal sphincter?
Yeah, they don't. Prostatitis is inflammation of the prostate. Pyelonephritis. What is pyelonephritis?
Urinary infection of,
Pardon me?
I was gonna say infection of the kidneys?
So yeah, it is inflammation of the renal parenchyma of the pelvis, which is that kidney. It can present with upper UTI symptoms such as fever, flank pain, in the costrovertebral angle tenderness, along with lower UTI symptoms such as dysuria, urgency, frequency for these patients. So again, this is a very busy slide, but it shows you just all what I went through 1 through 8, how we make that urine. Very busy, but it's a pretty good slide. How maturation takes place again. Again, it's just showing you what happens. Remember, once it goes past that 500, that's that tipping point. Let's take the break. It's 9, it's almost 10 o'clock. So all the way in the back, my friend, what's the normal sodium?
135.
Pardon me? I can't hear you.
135 to 145.
Okay, how about potassium, Mr. Sir?
3.5.
How about chlorides? As she peaks.
95 to 105.
Okay, so we know that when we are micturating or urinating, right, it regulates these concentration for us, right? It also helps in blood normal pH. Normal blood pH?
7.35.
No, wrong. What's normal blood pH?
7.
No.
7.35 to 7.45. I thought it was
No, that's not. What did you say?
Oh, I said 35. Oh, I'm sorry.
It's 7.35. It's not 7.35. There's no such thing.
7.35 and 35?
It's
So like
7.35.
After the
35
point,
is a
it's like
fraction.
just separate like digits. So it's not like just
It's
a
not a whole number.
Yeah.
Can't say that. We've been saying this since mod
The
1.
whole numbers would be like 35.
You cannot say that. It's wrong. It's like saying, I'll give you $2.50, right? If you say $2.50, that's completely different, right? Because that point is gone from there. That might be $250. That's not what I'm giving you. I'm giving you $2 2.50, very different.
But it said
35.
Yeah.
You cannot have a whole number after a decimal. Nowhere in math. I don't care what part of the world you're from, my sister. It's wrong.
There's a lot in that that you.
I'm so mad.
I'm the captain.
Did
You just make this up, Miss Jen.
No, I'm not making it up. Look it up. You cannot say 7.35.
Like, okay, so you
can. 35 or 35.
You cannot say 7.35. I'm sorry. See, you're messing up my head. Stop it.
Somali man.
I don't get it.
It's always right. When you got the right, okay.
Right? So any alteration in these problems will cause the person to have incontinence. So urinary incontinence diagnostic test, right? Clean catch urine. My friend Jess, talk me through how you get a clean catch urine.
You wipe front to back, and then you,
I'm a man, I have a penis.
oh, well, I think you pee a little bit the first, and then you,
No, clean catch urine.
uh,
So how do you wipe?
well, I don't know about the men. I have to look it up.
You wipe the head of the penis.
You wipe the head of the penis, okay?
Like
Go on, clean catch, go on.
And then you pee a little,
Mhm.
and then you catch the rest, don't put that in the cup, I can't even, God, hold on. You pee a little, and into the toilet, and then after that, you stop yourself, and then you put the rest into the cup. I don't know if that's correct, but.
Everybody correct?
Yeah.
Okay. Midstream urine is the same. Clean catch, you want to wipe it and catch that pee, right? We also, we're looking for bacteria, we're looking for RBCs, any of these things in the urine. Blood samples collected to measure urine blood nitrogen, so your BUN. So, sir, oh, I like your hair. What did you do different?
Yeah.
It looks like it was teased,
I
right?
think it's just getting longer.
Huh?
Then it looks like it's just getting longer.
Just getting longer. You used to wear a headband? Yeah. Okay, maybe that's what it is. BUN. Normal BUN.
3 to 5.
BUN. Look it up. Your sister in the back will tell you.
10 to 20.
10 to 20, not 3 to 5, okay? So BUN, common BUN is important. Remember, if your BUN is elevated without your creatinine, what do we look at?
Liver? Or kidney?
Look at nutrition, look at diet, look at something's going on with protein nutrition or so, right? If the kidneys aren't functioning properly, an increase in creatinine might be seen, right? If it's doubled, then we might be in renal failure. You gotta be very careful. A serum creatinine test measures the level of creatinine in the blood and provides an estimate of how well that kidney is functioning. And we also look at the glomerular filtration rate. Diabetes can contribute to urinary incontinence through what? Why diabetes? Why would a diabetic person get urinary incontinence?
One of the 3 P's,
Pardon me?
one of the 3 P's, polyuria.
Okay. Goes a little deeper. Polyuria alone wouldn't give you incontinence. Do you see what I'm saying?
Yeah.
Go to the physiology of the
Is it a
cell.
hormone?
Glycosuria. It's the glucoseuria microvascular damage. Remember, the high sugar is damaging the lines of that kidneys, right? And so it's gonna make things drain out a little more that shouldn't come out. So it's damaging the lining of that kidney. Right. So that's why with your diabetics, you want them to control the amount of sugar they have. Diabetes is a killer, right? When you look at somebody and you really don't know. Cool, we look at that. So, you're up, my friend. Tell me what is, post-void residual.
Post void, so after you go, you still have to go again.
After you go, you still have to go again. Are we agreeing with her?
Yeah, I'll better say yes.
Or is
Sorta.
that just the residual in your body?
It's what's left over in there.
It's what's left over in the bladder. So after you went, there is something left over in the body. What constitutes a post-void residual, Natalie?
What can constitute?
What constitutes a post-void religion?
God. Father, the Son,
Well,
and Holy
he has a
Spirit.
lot to do with it, you know? Who believes that God is a he? Let's not go there. Where the hell did that come from, Jeff? I'm having some religious conflict right
Yeah,
now.
it's not too much Ariana Grande, huh?
Pardon
God is
me?
a woman.
Too much Ariana Grande. What constitutes to post-void? So you need to
Medication?
know how much is in that bladder to tell you that you have post-void residual.
50 milliliters.
So more than 50 mLs tells you that you have a problem, right? So that you have a problem. So the amount of urine remaining in the bladder after voiding, right? One method to check this is catheterization. However, this can only be done, catheterization can only be done on somebody who is what? Cognitive. So when the person voids, they will call you immediately, you the nurse, and say, hey, I just peed. You have to have everything set up in the room, which means you have to have a Foley catheter ready to go. So you can cat that bladder to see how much pee is in there. Remember, if you look at the anatomy of the bladder, urine is constantly coming in. It's not gonna stop, right? Urine is constantly coming in, so you've gotta catch it immediately after that person voids. What's the second way of doing it? Ultrasound. So you have the ultrasound in there, and as soon as the person voids, again, the person has to be cognitive, right? You can scan the bladder and see if there is normally less than 50 ml remains in the bladder. So if more than 100 and normally less than 50 ml remains in the bladder. So if it's 50 ml, then people are okay, right? More than 199 ml or more than 200 ml, so we're close, reflects inadequate emptying. So anything more than 50, right? 199, a patient is not emptying their bladder completely. They have residual volume,
But
post-void residual. Any questions on that?
yeah, in the book it says a volume up to 200 milliliters may be acceptable. So is that
More than 100 mLs reflects inadequate emptying. Inadequate emptying. Read what the book says.
it says less than 50 mLs of urine remains in the bladder after voiding, but in older adults a PVR volume up to 200 milliliters may be acceptable.
I guess if they're older, I'm not gonna argue with that. But in a younger person, you should be able to empty your bladder completely when you pee.
217.
But you will see anything more than 199 reflects inadequate emptying
It
of
says
that
post-void
bladder.
residual
Again,
volume.
remind patients to call you, right? So post-void urine, PVR. So there might be obstruction. In that bladder, why the person is not doing it. So urinary incontinence imagery can be done, right? Tomography, CT can be done, MRI can be done. Again, if any of these are done, it is your responsibility of a nurse to make sure that these patients are safe to go down to the lab. You do urodynamic testing. What is urodynamic testing? It assesses the neuromuscular function of the lower urinary tract. Urodynamic testing are used to diagnose patients who have urinary incontinence or lower urinary tract symptoms. These tests are given to both men and women. Urodynamic testing are used to measure nerve and muscle function, pressure around the bladder, and the flow rate and other factors. The tests look at how well the bladder sphincter and the urethra are storing and releasing urine. Any type of urine leakage or incontinence, if the person has these, the doctor might order a urine dynamic testing. Sudden or overwhelming urge to urinate, frequent urination, pain when urinating. If they're having frequent UTI, right, the doctor will order a urine dynamic testing. What is urine dynamic testing? How is it done? Anybody? So usually it's done in a clinic, right? And what they have is this, if you see over here, this commode, right? And it has a pressure sensor in there. So when the person voids, it can calculate the flow of urine. It can calculate the flow of urine. So it gives you the pressure. So it measures the flow and the force of urine stream during urination. It is common, non-invasive test used to diagnose symptoms such as pain during urination or urine incontinence. Result from a urine flow can help with assessing the bladder and the sphincter's function, or to test for obstruction in the normal flow of the urine. So you have this special cup. So is there any preparation for this test? So there is no need to fast or anything for this test, right? Some meds might be held that can affect the test results. Patients are instructed to drink several glasses of water because you want them to void before the test is performed with a comfortable bladder. The urine flow will record the urine output and the flow on a chart. So it will have a manometer that is attached to this. And so you'll be able to read that manometer. Tells how long it takes for that person to void. Cystometry. What is cystometry? What is cystometry?
Does it measure how much the bladder can hold?
So definitely, it is used to measure the amount of urine in the bladder compared how full the bladder feels, right? So the person, my bladder feels really full, and they measure it, and it's probably half full, right? It is often used to diagnose problems with the main muscle of the bladder. What's that muscle name again? The detrusor muscle, right? Or sometimes it's used to diagnose urethral sphincter problem. It also can help identify with nerve response between the brain and the urinary tract, which can affect bladder control and lead to urinary incontinence. Cystometry is a common urine test with a few side effects. It is a valuable tool in planning the course of treatment, usually done in the doctor's office. It takes about an hour. No prep is needed. Some meds might be stopped again. During cystometry, before the test begins, the patient will be asked to empty his or her bladder in a toilet that is connected to a machine. Again, remember that machine that we saw before, they will connect it to that. Then they will be asked to lay on their back for an examination. The doctor will put a cystoscope in, right, and look at that bladder. Measurements will be taken, and the urine remains in the bladder pressure, they'll look at that. Sometimes they might put a catheter in, you may also have a catheter or probe inserted in the rectum, or adhesive electrodes may be placed on either side of the anus opening. The bladder will be filled with water. If there's a Foley catheter, they'll fill the bladder with water, or sometimes contrasting solution, depending on the doctor. And then they'll ask the patient to describe sensations for them, full, not full. And then of course they can check the pressures as they go along. Once the bladder is full, the patient will be asked to urinate while the pressure is being recorded again. Is there any discomfort for the patient? Yeah, there might be some, they might experience some discomfort. So as nurses, we need to tell them that, that they might have some discomfort. When the test is all done, they'll remove the catheter, they'll remove the rectal probe, they will remove all the patches from these patients. Provocative stress test. What's a provocative stress test? Very simple. Doctor asks somebody to cough or laugh while they're up on stirrups. What are they looking for? They're looking to see if there's a little bit of pee that spills out, right? So the bladder stress test stimulates accidental release of urine when the person coughs, sneeze, laugh, or exercise. Right, very simple. And which people would have this?
People who had children,
Huh?
like somebody who gave birth.
So somebody that gave birth, yeah, especially people that give large baby birth, right, or mini birth, right, multiple pregnancies can cause this, or multiple babies in one pregnancy. It really causes the sphincter muscle not to hold, right? As women get older, they tend to have leakage. So those things might happen. A cystoscopy. Cystoscopy. This is where a scope is inserted into the urethra and it visualizes again that bladder. Can do it under anesthesia, can be done without anesthesia. Post-procedure, monitor the urine, right? What will the urine look like post-procedure?
A little red.
Huh?
Have some blood in it.
Yeah, but pinkish. If it's frank blood, we have a problem. It shouldn't be frank blood, it should be pinkish. So for patients that have incontinence, we want to bladder train them. Therapeutic measures for urinary incontinence, right? Bladder training is important form of bladder therapy that can be effective in training urinary incontinence. The goal may be to increase the amount of time in between emptying the bladder and the amount of fluid the bladder can hold. So as people get older, maybe they have to go very quickly. It can also diminish leakage and the sensation of urgency associated with the bladder, with the problem. As our bladder training requires following a fixed voiding schedule. So you can't do it in the morning and the PM nurses decide they are not going to do it. They all have to cooperate. If the patient feels an urge to urinate before the assigned interval, he should be urged, you want to urge them to suppress that. Suppress technique. So if you're going every 3 hours and the patient at 2 hours says, I really need to pee, teach them the urging suppression techniques, such as relaxing and Kegel exercises to try to suppress. Have you ever driven long distance and you want to pee, but the next rest stop is half an hour away? Do you stop the car? I'm not talking to the men. because they will stop the car and get out at the side of the road. Unfortunately for us women, that might be a little harder because we have undergarments on. Or some of us don't wear undergarments, but it's a little harder, right? So, what are you doing? You just stop the car and get out?
No,
Okay.
my husband just pees in the car. He just gets bottled.
Oh,
One of the students in mod 1 was telling me there's a new device where women can pee in the car now,
Oh, yeah.
right? It's called a wee wee something.
There's one called Camper Girl or something.
Mm-hmm.
From 15 to 30 minutes increment until it is possible to remain comfortable for 3 to 4 hours. So we've got to have these patients not go to the bathroom every 15 minutes, but maybe every 3 to 4 hours. The goal is can the the goal can be individualized to suit each person's need. Keep a diary for these patients, or ask them to keep a diary. This helps to determine the correct place to start and where to train them at. The next is habit training. Habit training, urinary incontinence is common in older people, especially those with physical or cognitive impairment. Very important, right? Because bladder training, the person has to be pretty much cognitive. For habit training, it can be done on patients that are cognitively impaired. Habit training involves identified incontinent patient's toilet pattern and develop individualized toileting schedule to prompt individual bladder emptying. It can be very labor intensive when you're doing this. So habit training, void every 2 to 3 hours while awake for these patients. Remember, they are not able to do this on their own. You're gonna have to prompt them. So remember the things you learned how to get somebody to void. Leslie, what are some of the things you learned how to get somebody to void?
Put their hands in warm water or
Put
run
their
the
hands
water.
in water.
Run the water. Touch the thigh.
Dangerous one, but yeah.
Or
Rub the inside of their thighs. We can do that. I
Can
just
they do
caution you on that.
can they do it themselves? Will it be the same
Say what,
effect?
sweetheart?
If they rub their own thigh, will it be the
They can
same?
rub their own thigh, yeah. But I caution nurses on doing that one. Throwing water over the pubic area. Warm water over the pubic area. Running water, right? Putting their hands in water. Any of those things can get that person to void. Prompt voiding. What is prompt voiding? Often used with habitual training, who are dependent or cognitively impaired. You check the patient for wetness at a regular interval and ask the patient to state whether wet or dry. Caregiver encourages the patient to try and use the toilet. Again, these things are labor intensive. That's why a lot of nursing homes don't do it. But I would prefer for somebody to train these patients than to have broken areas of their bodies. It is labor intensive. And you find the long-term facility that invest in this have better outcomes, really better outcomes. Pelvic muscle rehabilitation, right? This aims at strengthening the pelvic muscle. So those are your Kegel exercises, right? Biofeedback or vaginal weights. So if you go to the sex stores, right, you can buy the vaginal weights and put them in for these, or if they really want to use it, or you can buy it online, especially for women. I think they can do it. However, breathing. How often do how do you do your Kegel exercise? You contract for 10 seconds and then relax for 10 seconds. You want to do them sequentially, right? So that you tighten and relax. 3 to 6 seconds, release. And you want to do it for 5 or 6, sometimes 10 times. So those are your Kegel exercise. Trying to explain what it is to somebody. Urge suppression. Remember I said talk about urge suppression? When you feel the urge to urinate, stop the activity. Teach the patient stop. Sit down if possible. Try to stay very still to maintain control. Avoid rushing to the toilet. You want to perform your Kegel exercises quickly, 5 to 10 times. Again, strengthening up that pelvic flow. Do not rush to the bathroom. Take deep breaths. Let the urge pass. Then the patient gets up and walks to the bathroom normally. Now, it takes a lot of time again to teach that patient how to do that.
Does walking really fast, like,
Say what?
you said avoid rushing and then walk to the toilet.
Normally.
Does walking really fast make them pee?
You know, if that's how they normally walk, right? To get to the bathroom. It's again trying to suppress that urge and getting that control back under thing. So while continuing to squeeze the pelvic floor muscle, walk to the bathroom at a normal pace. I stuck the slide in there. I found the key features of the 3 bladder training, and I thought it would be good to stick in there. Bladder retraining, schedule training, habit training, and some important factors to remember. There's some therapy that is used for this drug for bladder incontinence, and I know Dr. G went over some of these drugs with you. Anticholinergic drugs block the action of chemical messenger. What is that chemical messenger again? Acetylcholine, right? That sends signals to the brain that triggers abnormal bladder contraction associated with overactive bladder. So these bladder contraction can make the patient feel the need to urinate even when the bladder is not full. The most common side effect of acetylcholine would be what? Dry mouth for these patients, constipation. So if you're giving this, make sure that is part of your care plan. So acetylcholine good for urge incontinence. So oxybutynin is one of the acetylcholine that can be used. Detrol, D-E-T-R-O-L. Tovaz, T-O-V-I-A-Z. Festorodine, I think is the other name. Calcium channel blockers decrease smooth muscles contractibility. And the bladder is a smooth muscle, so it will decrease that. This causes urinary retention and additionally leads to, and accordingly leads to overflow incontinence. Sedative hypnotics result in immobility of the secondary to sedation that leads to functional incontinence. We can use tricyclic antidepressant. Tofenil is one of the drugs that we use. Tofenil for stress incontinence. It causes the smooth muscles of the bladder neck to relax. It can also treat mixed incontinence. Maybe somebody might have two different types of incontinence. However, this drug is an antidepressant. It will cause drowsiness. So safety, remember Maslow will never fail you. Safety is one of the things that you're gonna look at for this patient. So we can also use it because of this. Ibuprofen may be useful for nighttime incontinence as well. It may also be helpful for children who wet their bed, nocturnal emeresis. So it's not a good fit for older adults, again, because of the safety issue. Alpha adrenergic, which is used for stress incontinence. Alpha adrenergic results in contraction of the internal urethral sphincter, and it increases urethral resistance to urinary flow. We can use estrogen for postmenopausal incontinence, urge or stress incontinence. Remember, women after menopause makes less estrogen. This drop in estrogen may contribute to deterioration of the supportive tissue around the bladder and the urethra, weakening the tissue and potentially aggravating stress incontinence. You can also use your 5-alpha reductase inhibitors, which are used for your BPH. What is BPH? What does BPH? Benign prostatic hypertrophy or enlarged prostate, right? One of the drugs I think Dr. G talked about was Flomax, I'm sorry. Did she talk about Flomax?
Mm-hmm.
Flomax can cause dizziness, drowsiness, and weakness. So please be careful of this drug. Then you can use urethral bulking injection. This is a procedure that is used to treat urinary incontinence in women. During the procedure, bulking agents are injected into the wall of the urethra to close the sphincter. The goal of urethral bulking injection is to help the patient gain control over the urine flow. This procedure is used for stress incontinence. Sometimes after they put a urethral sling in, they might use this for stress incontinence. So urethral sling will be, they have to go to surgery to get that. So indwelling catheters can be used. Remember, we have balloons with these. We talked about these earlier. When you put an indwelling catheter in a patient, you can use external catheters, your condom catheter. When you put a condom catheter on, Natalie,
Yeah.
What is one of the things we have to remember on the condom catheter?
The size?
The what?
The size?
Okay, so the size. How else when you put it on? What's one of the things that we must remember?
To clean it before you put it on?
Okay.
Don't break it.
Pardon me?
Don't break it.
Don't break it.
Lubricate.
Lubricate it.
Lubricate. Okay. It comes pre-lubricated.
To pull it down.
Pull
Oh,
it
the
down.
skin, and then put it
Pull
over.
what down?
Here, the skin, you got-
The skin. Let's say foreskin.
Force.
Okay. Let's pull the foreskin down. Okay.
And then you have to put it back up. You have to pull the foreskin up.
Up and down. Pull it up first. Then up.
No,
You have
you
to
pull
put it
it
back.
down and then you pull it up.
That's it.
Over
Pull
the
it back.
back.
That's after you take them, get off.
Okay.
Wait, so when you put the condom catheter on, you leave the skin down?
Because if you put the skin up and you pull it up, it's gonna choke it.
It won't cause what you said when it,
What is the term?
I forgot.
Phimosis.
It won't cause that?
If the skin is down, no. The skin is down. If the skin is back, right, it's gonna cause phimosis, cause that skin have to come down. The skin should be down.
But I thought when you said when you put a catheter, a regular, not a condom catheter, right?
Okay, we're talking about condom catheter now. When we're talking about a regular catheter, we're gonna pull that, if it's a regular catheter, right? You pull the foreskin back. When you already put it in, then you pull the skin down,
Because it's already in the bladder.
cause it's already what?
Because it's in the bladder, right?
Oh, yeah.
Because if not, it will cause phimosis.
Uh-huh.
But with a condom catheter, it won't cause phimosis if you leave it down.
You won't put the skin will not be back when you put a condom catheter in.
Yeah, 'cause you're
You won't pull back.
like,
You'll just roll it right up over the penis.
So you don't even touch the skin with the condom?
You don't have to put it. Not put it. What I was getting at is that there have to be a little bit of outage on that catheter. Remember, 1 to 2 inch at the tip of the catheter. So this is the penis. So you got 1 to 2 inch that is
Space.
out from that catheter, right? And then you connect the drainage back. Pure weak catheter can be used, and I use you as my, I hope you I do, I don't call your name, but, that just really hurt me, that some stupid nurse will have you do that.
but
Oh,
I don't
that-
think she knew like how. to
Right,
use
but
it.
she's
It was
supposed to
new in the
have
hospital.
learned, you know?
Did she actually inserted it in the patient?
Huh?
Yeah.
She inserted it in the
But
patient.
She
was-
inserted
okay,
it
she
in the
was a teenage
vagina.
Girl, she wasn't like a little baby, because that would have been like. But I didn't know what it was either. I was just like, I don't know if it's supposed to be in there, because I'm the I was like, okay. Because I didn't know. I've never seen it before.
So, if you don't know something, ASK, please ask. Okay. And then the PP wick, PP whatever this thing is, you know what it is? You seen it before? The thing where people can pee in their car? I gotta look it up.
We have it on Amazon.
I say what?
Amazon.
I guess I'm gonna go buy one off Amazon. Intermittent self-catheterization, right? Remember when somebody's self-cutting themselves, this is a clean procedure. As long as a nurse is cutting a patient, it is a sterile procedure. I'm not having any arguments about that.
Even if it's just
I don't
a
care
straight cat.
who's telling you anything different. What are you saying?
Even if it's a straight cat.
Even if it's a straight cat and a nurse is doing it, it is a sterile procedure.
Okay. No straight nursing.
If you're having problems with somebody else, speak to me offline. There is also garments and pads that can be used. I love that there was a commercial once where this older woman went to some store and she wanted some incontinent pads, and the person went over, she brought them and they were checking the price, and they went over the PA, can you please check, you know? Very embarrassing for older people. So if they're using this, you know, be cognizant of that. Penile clamps can be used. So these are clamps that you put on the penis. And so it holds down like this on the penis. So when the guy feels like, so it stops dribbling. So when they feel like they have to go, they release the penile clamp and then they can go. It's
Wouldn't
soft.
that interfere with like circulation?
It's soft. So, I mean, they're not gonna have it on there for 24 hours.
Oh.
It's like every 2 hours you're gonna release it, or 3 hours so they can pee.
It
But
doesn't
it-
hurt.
No.
Like some torture
It-
device.
I know, right?
It interferes, I mean, it's used for dribbling for incontinence. So rather than using a pad, they'll use this penile clamp. I'm gonna be honest with you, I've only seen it once on a man before. He came into our ICU and he had it on, and like, what the hell is this?
His wife put it on him so he won't cheat.
That hurts.
It's not a chastity belt, Natalie. I think by this time he's probably.
Good save.
Yesterday I was telling my priest, he says, how do you teach? You have no filter. And I says, my students understand that. I says, that's why I teach, because you tell it like it is. Okay, women can use Paseo valves. Have anybody seen this before? The Paseo valve is inserted into the vagina, right? And what it does, it has to come out every so often for cleaning. So they have to come back to the doctor and take it out so that they don't get smelly. Okay, so they're fitted for it. After 24 hours, somebody should be checking these patients once they put this Paseo valve in, and they must be removed periodically and replaced as needed for cleaning. Okay. Bladder neck support prosthesis. Oh, let's go back to bulking. I forgot to tell you the drug, one of the drugs that is used. Anybody know the drug? Botox. They use Botox down there, yeah. So, you know how it relaxes things. It can relax sphincters in areas. Help with that if that's what's causing the problem. Surgical treatment for incontinence, right? Surgical repair, special procedures, removal of obstruction. So if body have obstruction, they can use a TURP for these patients. For male, remember women, we can't have TURPs, but they can use TURPs. They can treat severe detrusor overactivity, right? Probably put in some kind of nerve stimulator, implant artificial sphincters, reposition the sphincter. Remember, whenever you start having surgery on the urinary tract, it is so complex that these patients will have to have surgery over and over again. It's one of those areas that surgery just doesn't go well, right? Injection of substance that increase urethral compression will be Botox, right? Implanting of electrodes, like I said, retropubic uroplexy or provaginal sling. So these patients may have Marcia Marchetti. Remember what Marcia Marchetti is? Anybody? Marcia Marchetti repair? MMRs?
Oh, the mesh?
No, it is where women that after they're done giving birth, right, they have to be finished having babies, they go back and they tighten up down there. And so it might decrease urinary, where they leak pee. So they have that whole area tightened up down there.
Is that for vaginal births?
For vaginal birth, yeah. I told you about my sister-in-law having hers done, and my brother-in-law was very happy after the procedure. It's like, why didn't you tell me about this alone? It's not me, your wife. Don't call me and tell me about what's going on. So, artificial sphincter can be implanted for these patients, okay? So electrodes, like I said, can be implanted to stimulate those muscles. They could put non-absorbent sutures. Artificial sphincters can be implanted. Again, whenever you hear anything with urine, they're so complex surgery. I told you one of my good friends, he is an OBGYN. However, his specialty was OBGYN with urethral specialty. So he was the guy that trained all these Kaiser doctors, you know, and every time I see him, I was telling him I met my hematologist on Tuesday. I had a meeting with my hematologist, an appointment with him, and he was very handsome, very young guy. He's Asian, good-looking fellow. And so I'm telling Dr. Yesterday I was telling Conrad, and he was so funny. He goes, "I'm glad it was a hematologist and not an OBGYN." He goes, "You know, we had to be very careful." And he's a good-looking guy. Conrad is about 6'7". You're about 6'7", yeah. So he's tall like you. He's a big guy. And he goes, "Yeah, I've got to be very careful, Jen." You know. I'm going, "Okay, Conrad." He's a nice chocolate man. So I'm like, he goes, "No, I couldn't like my patients." Okay, types of urinary incontinence, transient urine incontinence. When you hear the word transient, remember it's not for long. So there is this acronym of DRIP, right? What will cause transient urine incontinence? Sometimes delirium, right? Dehydration will cause transient urinary incontinence. Restriction or immobility for these patients, infection, or fecal impaction might cause them to have transient urine incontinence. And then of course the P's, right? The polyuria, polypharmacy, pain, right? Remember, it's just for a period of time. If you can control these things, they can get better, right? Persistent urinary incontinence, right, can be stress, and we talked about that. Urge incontinence, mixture of the two, overflow incontinence, or functional incontinence. I found this little diagram that shows you the different type, right? Stress incontinence, too little, for stress incontinence, too little tone. The bladder tone is lost, right? So you're gonna drip, drip, drip. And urge incontinence, too much activity. So you're not following the urge to go pee. And then overflow, just can't hold anymore, right? And so the person is gonna wet themselves. Stress incontinence, involuntary loss of the amount of urine during physical activity that increases abnormal abdominal pressure, right? So remember, I said coughing, sneezing, lifting, any of these things might cause stress incontinence. In women, caused by relaxation of the pelvic floor, right? Pregnancy, obesity, aging, childbirth. Urethral trauma may cause this. So remember, that's why one of the things we don't do is blow up that balloon, because we can cause urethral trauma, sphincter injury, congenital sphincter problems for these patients, right? Urine infection can cause it. Neurological disorders. It may occur after after a prostatectomy or radiation treatment for men. Management, behavioral method, right? We can do toileting program, pelvic muscle exercise, so those are your calyx exercise. Maintain fluid intake in these patients, so that at least 2 liters, as long as it's not contraindicated. Oral or topical estrogen if it's a woman, right? Sometimes they might have to have MMRs. Certain things that you would put into teaching for them. What would you put into teaching for these patients? What fluid would you tell them to avoid? Alcohol, tea, coffee,
Avoid
right?
caffeine.
These things have diuretic effects. Cola, right? So people might want to stay away from something like that. Please don't take my coffee away from me. Urge incontinence, the involuntary loss of urine shortly after a strong, abrupt urge to urinate. right, associated with caffeine products, tobacco products, UTIs, bowel impaction. So again, check your patient. When's the last time did they poop? Dehydration, neurological disorders, Parkinson's disease, MS, spinal cord lesions. Management aim to correct the cause, fluid hydration, eliminate any stimulants that these patients are giving, smoking cessation, antibiotics if they have infection, and then make sure that they're pooping. Behavioral techniques, we can give drugs, right? We talk about anticholinergic or antispasmodic. Mix, which is a tool, stress and urge incontinence. Right, we talked about that earlier. Overflow incontinence, distended bladder, small amount of urine is lost continuously. Contributing factor, obstruction, right, in the UT tract, in the urinary tract. Patient not aware of the bladder being full. Neurological problems could be that's the reason why they have to have surgery. Depends on the cause, again, how it's treated. Physician may prescribe drugs to stimulate the bladder to relax. Surgical removal of the prostate. A sphincterectomy can be done. Intermittent or indwelling catheter. The Crede is C-R-E-D-E. Is that how you spell it?
C-O-U.
No, it's C-R-E-D-E, Crede. Crede,
Is it different?
C-R-E-D-E,
Yeah,
C-R-E-D-E,
Oh, that one's
with an
different.
accent on the E, right? There is also a Crede maneuver. How do you do the Crede maneuver? So over the bladder, you cup your hands like this and you push down. Over the bladder. Right, a Crede maneuver used to void urine from the bladder of an individual who, due to disease, cannot do it without aid. The Crede maneuver is executed by exerting manual pressure on the abdomen at the location of the bladder just below the navel, just below the umbilicus. The technique is described to facilitate voiding, especially in a paraplegic patient, whereby external sphincter spasm is eliminated as a source of obstruction. Digital stretching or anal stretching combined with valsalvic maneuver has resulted in satisfactory bladder emptying. So sometimes you have to go in, stretch the anus for these patients and do the Crede maneuver. Functional incontinence, voiding inappropriately because unable to get to the toilet or to manage the mechanism of the toiletry, right? They cannot put the toilet seat down or they can't get there. Related to confusion, immobility, barriers in the environment. Functional. Wherever it's functional, it has to do with your environment. Depends on the cause. Arrange things for these patients. The confused patient may respond well to schedule or time voiding. Types of urinary incontinence, we went over this. This is just showing you that again. So when a person have urinary incontinence, do a health history. Why are they there? What meds are they taking? Are these meds contributing to the problem? Now they turn these black. Check diabetes on these patients, right? DM may develop neurological problems that affect the bladder and and make it uncontrollable for them. They may produce large amount of urine also. Do a physical exam on these patients, right? Measurement of their vital signs, their height, their weight, be alert for fever, tachycardia, right? Is this patient having an infection? Level of consciousness. Inspect the skin, right, for edema. Palpate the abdomen for any mass that this patient might have or tenderness. Inspect the female perineum for redness or irritation. Assess the environment where this patient is. Intervention, general strategies for bladder health problem. Void before and after meals and at bedtime. After drinking 6 to 8 glasses of water, make sure they're aim to drink that, right? Which is about 2 liters of fluid a day, 1,800 to 2,000 mLs. Get regular physical exercise, get your patient up. Pelvic exercise, teach them the Kegel exercise. Avoid caffeinated or anything that can hyperstimulate that bladder. Ensure proper bowel movement. Remember, constipation can lead to urinary incontinence. Praise your patients when they did a good job. Inadequate knowledge, so make sure your patient and family knows how to teach them. The reasons why you're doing this. Decreased socialization, right? If you're constantly smelling of pee or you cannot maintain your urine, you cannot go out. You cannot socialize. Impaired self-concept. Make sure that these patients are taking active role in their care. Potential for skin breakdown, right? So make sure that we're looking out for that. Potential for urinary infection. Concentrated urine is risk for infection and for calculi, for stone formation in these patients. So that's why we need to make sure we're giving them enough water. Bowel incontinence, right? Again, people can have leakage of stool. Usually relates to the sphincter dysfunction. Some experience temporary incontinence with severe diarrhea. So it might be just transient. So when somebody have fecal incontinence, we give them a brat diet. What's a brat diet? And I'm not talking about you.
Like bland.
Bread, rice,
Huh?
bread, rice,
Bread, rice,
apple, like, what?
apple,
And
toaster tea.
toast.
So we want to give them a brat diet. So things that will thicken the stools. Bread, rice, banana, cheese, yogurt, oatmeal, boiled milk. Don't ask me about it, please. Pasta, anything that will thicken the stools, you can give these patients to eat. The physiological of defecation, right? Again, it is under voluntary control when we want to go to the bathroom. There are a lot of nerves involved, right? Defecation occurs when the anal sphincter relaxes and the rectum contracts. We saw this the other day when we were doing some lecture, I can't remember what it was. Diagnostic procedure, evaluation of bowel incontinence, assessment of the rectal sphincter tone, a lab exam of the stool specimen for blood and pathogen. Remember, blood in the stool is a very serious problem. So what color? What color can you see? Black. What does that mean?
Upper GI.
It means it's coming from higher up. What does red mean?
Lower.
It's lower. Is there any other way we can have blood in the stools?
If you're forcing it, like,
Hernia,
yeah, like when you're forcing
Huh?
it.
hernia, like if
Microscopic blood could be in the stool. How do you see microscopic blood?
Under a
If the
microscope.
patient's not having black poop
A cold
or they're not having
A fit
red
test.
blood, pardon me?
The fit test, the cold blood.
A cold blood test, guaiac test, right? That's when we can see microscopic blood in that stool. Endoscopy can be done, upper, lower. Okay, the three different endoscopy, upper, lower, or what's the third? Come on, you guys, didn't have coffee this morning. Upper, lower.
You said a what?
Three different kind of endoscopies that can be
Oh,
done.
the
Upper,
the pill.
lower.
The pill, the camera.
Okay, capsule endoscopy, right? To detect, to see what there are underlying problems. Enemas, how much can you give on an enema?
500?
To 1,000.
To 1,000 mLs. Okay, what if the person has a, como se dice, colostomy? How much can you give for an irrigation? I did this in Mod 1. Don't you hide behind her, I see you. How much do you give? Thank you,
100?
Leslie.
No, I don't recall either.
How much do you give?
1,000?
The same as giving an enema, 500 to 1,000 mLs of water. Where do you put the enema bag or the bag when you're irrigating the colostomy?
Up high?
Not too high.
I'm gonna go what you said now, up high. So if I go up high, what is that flow gonna be?
There is
Fast.
gonna be flow.
Fast.
It's gonna be very fast,
Rapid.
and it's gonna cause abdominal distension, abdominal discomfort. So do you see where the little drip thing is? You're gonna put it at shoulder level. Shoulder level, so it's about 16 to 18 inches above that patient, about shoulder level, right? You don't want it too high. So enemas, and remember enema, you want to use warm water. I did not say hot. Did I say warm? Okay, pouches may be applied for, over the pericare. So I've never done this in an adult, but, sometimes they put a pouch over the peri area. I've used rectal tubes, right, to collect poop. Drug therapy can be used, laxatives, stool softeners, anti-diarrheal medication if they're having diarrhea. Biofeedback can be used, dietary changes. So get these people to have fiber, especially if they're constipated, if they're dietary changes, raw vegetable, fruit juices, prune, grape juice, right? To sort of have them have regular bowel movements. And then remember food that will thicken up the stools. Banana, rice, potato, cheese, yogurt, oatmeal, oat bran, boiled milk, pasta. Bowel overflow incontinence caused by constipation, in which the rectum has a lot of poop in it, but the stool is coming around it, right? Medical treatment, immediately relieve that constipation. So for patient, cleansing the colon, giving enemas sometimes, or giving medication, regular evacuation, digital evacuation. For these patients, remember Valsalvic maneuver can occur. Neurogenic incontinence, defecation is not under voluntary control. This is where the person have lost that control. 1 or 2 form stools occur after meal. Scheduled toileting based on the usual time of defecation. Sometimes you might have to order drugs that causes constipation. What's one of our big drugs that cause constipation? Codeine. But again, Maslow never fails you, right? The ABCs are not affected, right? But my safety is affected here, right? Codeine, safety, safety, safety. It's gonna make this person drowsy. Sometimes we might have to give laxative to these patients. Anal rectal incontinence, nerve damage that causes the muscle of the pelvic floor to be too weak. Treatment, pelvic exercise, sometimes biofeedback for these individuals. Look and see what your poop look like, right? Ask them history, patient with bowel incontinence, reason for seeking care. What does your normal poop looks like? Remember I says always look before you flush. Characteristic of the stool, medical history, functional assessment, physical assessment. Pencil stool, remember that one? Loss of bowel control, interventions for bowel incontinence. You need to monitor these patients. Look at their electrolytes. Document their usual pattern. Explain normal bowel physiology. Advise the patient to consume adequate amount of fluids. Roughage if that's what's needed. Potential for skin breakdown. Watch and make sure that area is not broken down. Impaired self-concept, again, if they have fecal incontinence. Remember, fecal incontinence can also be from an ostomy. So you've got to take care of that ostomy. Remember when you cut an ostomy bag, how much around that stoma? What is that around the stoma, sir?
I don't remember if it was 0.5 to or 1
No.
inch. Right?
How much do you leave?
1 inch?
Somebody's saying something.
1 inch?
1/8. 1/8 around that stoma, so it doesn't constrict that stoma.
1/8 of an inch.
1/8 of an inch around that stoma. What color should the stoma be? Should be nice and red, right? When the person have the original stoma, will it be large, will it be small?
It'll be large at first.
It will be large and it shrinks over
6 weeks.
6 to 8 weeks. Remember when you're doing, and we'll probably never go through this again, when you're doing when you're doing an enema or fecal impaction, or you're washing out the colostomy, you need to know how that colostomy position is going. Remember, the position of the colostomy sometimes dependent on the person's body size. Remember the term that I used where I said it's not a medical terminology, where people have more than one rolls in their tummy? What is that term? Pardon me? Panis. It's not a medical terminology. It is a street term, but it is used. So if somebody have a large panis, when the doctor does a colostomy, they're gonna have to pull that intestine up so that they can put it in a place where that person can see it and do it. So if you are doing an evacuation, you're gonna have to grease your pinky, lubricate your pinky, and push it into that stoma to see what direction to put that little funnel in. Are you okay? Okay, so remember, if you don't remember those things, please go back and look at that. That was all mod 1. Questions? Let's take a quick break, please. It's 11.